Hello, everyone. For those of you that have just joined us, this is Lisa Dulski-Watkins with the Milbank Memorial Fund Multi-State Collaborative. You are logged into or dialed into our monthly topical webinar series. I'm delighted to have our guest speakers, Rachel Block and Mark Friedberg, join us. Just a couple of housekeeping issues. If you are logged in or dialed in, please make sure that you are muted, either through your computer audio or on your cell phone or landline, just to make sure that we don't have much ambient noise. It's very helpful. And then obviously, if you have a question, you can unmute yourself and ask. As an additional option for questions, please feel free to use the chat function. It allows us to have a running record of the questions that will be asked and make sure that those get teed up and answered by Mark and Rachel when the time comes. This webinar will be recorded. Actually, we've already started the recording process, and we will have that available on our website if you have colleagues that would like to listen to this discussion and don't have the opportunity to do so right now. And in addition, the slides that you'll be seeing today are available to you as well. I'll be sending them out as an attachment after the webinar is completed, and it will also be available as a download from the Multi-State Collaborative web pages. So we'll just get started in a moment or two, where it's just shy of the noon hour in Eastern Time. Okay, welcome everyone. I guess we'll get started. It is 12 o'clock Eastern Time. Thank you very much for joining us today. This is Lisa Dulski-Watkins speaking. I'm the Director of the Multi-State Collaborative at the Milbank Memorial Fund. You are participating in our monthly topical webinar series where we try to address issues that have an impact on and perhaps can help with some technical assistance around the implementation of multi-payer primary care transformation. This topic is a little bit tangential to that, but I actually think still quite important. We're going to be learning about the primary care spending measurement, specifically from my colleague and friend, Rachel Block, who is a program officer at the Milbank Memorial Fund, and from Mark Friedberg, a senior national scientist at the RAND Corporation. Many of you know Mark's excellent work over the years. As I mentioned, this webinar is being recorded, so we will have options for listening to it at a later time if you have colleagues that would like to hear the presentation today and are unable to join us at the moment. And in addition, the slides that you'll be seeing will be available to you, both sent to you directly after this webinar, if I have your email address on my distribution list, and will also be available for download on our website. Just a quick housekeeping reminder, please put your phone or your computer audio on mute while our presentation is underway. Feel free to unmute yourself to ask a question. And if you do have questions that you'd like to make sure we keep track of, please feel free to use the chat function. It works very well and allows us to keep a log of questions and make sure that they get answered as we move through the presentation. So with that, I'd like to hand the speaking opportunity over to my colleague, Rachel Block.
Thank you very much, Lisa. Can you hear me okay?
Yep.
Great. And I see that Mark Friedberg is also on the line, so we'll just jump right into the presentation. Thank you all for joining us today. And what I'm going to do is just tee up a little bit of an introduction for the work that we've been doing on primary care spending measures. Mark is going to give you a little bit more technical information about the research that he has conducted for us, and I will then wrap up with some additional follow-up activities that we are currently involved in. So the agenda for this discussion, I'm going to be very brief about the Milbank Memorial Fund's role in primary care, because all of you who are on this call are quite familiar with that, but I will just touch on that. And then Mark and I will be talking about why we think it's important to measure what and how to measure the results of the study that we published last year, which Mark was one of the authors. And then, as I said, next steps and opportunities. Lisa, you can go to the next slide. I think you skipped over one. So I think you all know, but just in case, our mission at the Milbank Memorial Fund is to improve the health of populations by connecting leaders and decision makers with the best available evidence and experience. And as this particular project, the Multi-State Collaborative, is an indicator, we mainly focus on working with states, but we are also interested in alignment and engagement with the federal government and the private sector as well. So all of those elements are captured in the work that we're doing on primary care spending and the work of the Multi-State Collaborative. Specific activities that we're involved in, we build evidence through research support, and the project that we're going to be discussing today is an example of that. We disseminate and use that evidence through reports and convenings and other activities. And then obviously examples of things that we've done, the Multi-State Collaborative, which you're all quite familiar with. We published a couple of different reports on primary care and behavioral health integration, and last year, the report on primary care spending measures. Lisa, you can go to the next slide. So some of the precursors for this work that are probably helpful to understand. Rhode Island was one of the leaders in doing this work, and he's not on the call today, Chris Kohler, but we'll give him a big shout out because he got the ball rolling in Rhode Island on these issues. And also Oregon has been a real leader in terms of legislative efforts. We know that measurement activities are also going on in other countries. We're not going to be focusing on that so much today. Next slide. So in Rhode Island, the way this got started, Rhode Island is the only state that has an Office of Health Insurance Commissioner. Every state has an insurance commissioner, but Rhode Island is unique in that they have a health insurance commissioner. It's actually established in statute. And early on in the work of that office, they decided to focus on the affordability of insurance. And they had an advisory council that developed some standards that would be followed by the insurers, all of which I think are relevant to the discussion today, and also the ongoing work that all of you are involved in. But this is really where the concept of measuring primary care spending started in Rhode Island. As you'll see, it was part of a larger strategy. So we had all-payer medical home support, support for HIT adoption, and while not a focus for today, work on hospital payment reform. So really they conceived of this as an integrated set of steps, but where clearly support for primary care was a very important component. And they were able to use the Office of Health Insurance Commissioner's enforcement powers through the rate review process with the insurers. So that gave the requirements some teeth. Next slide. The next two slides, I'm not going to dwell on the numbers, but basically what you can see here is that as a result of adopting policies relating to measuring primary care spending and also related to the types of things that insurers were expected to spend on primary care, the good news is that the trajectory, as you can see from this slide, was generally in the positive direction. And if you go to the next slide, and obviously a significant investment, which is on that little sidebar animation that Lisa just clicked on. In addition to that, what you will see is very significant commitment to what we call the non-fee-for-service investments. So these were those activities such as shared care management supports, care managers in practices, HIT adoption, health information exchange, a lot of those kinds of things. So this is the proportion of spending on primary care that went into those non-fee-for-service investments. And we view that as investments in the infrastructure that supports better primary care practice. Next slide. So just keep clicking through, Lisa, because there's 4 components here. So this just illustrates the fact that in addition to the Health Insurance Commissioner's standards, there were a lot of other things going on that probably reinforced the investment and certainly helped to create a strong value proposition for the investment in primary care. So it wasn't simply a matter of regulating the insurers, but rather putting the investments that insurers were asked to make into a context of medical home activities, the development of a primary care-based ACO, a health insurance exchange, and ultimately the development of the multi-payer collaborative in Rhode Island. Next slide. This is just a slide shot. I probably should have updated this. I'm sorry. I think there might be folks from Oregon on the line. But this was one of the earlier state reports that Oregon published looking at their measurement of primary care spending. And Oregon has a significant advantage that they have been able to figure out how to use data coming from their all-payer claims database, in addition to some supplemental data that they collect to do these measures. And as you can see, they're able to look at this across many payers. I don't want to say all payers, but basically the CCOs, you see a reference there, are the Medicaid coordinated care organizations, a central component of Oregon's health system transformation strategy. The larger commercial plans, Medicare Advantage, which is insured by the same carriers as the commercial plans. And then the bottom part is the public employees and teachers benefits organizations. And so under Oregon's law and their data collection system, they're able to report primary care spending percentages and amounts across those 4 major categories of payers. Now, next slide. So why are we doing this? The operating premise here is that we improve what we measure. And I think many of you have seen some version of a slide like this where we're looking at total healthcare spending from a very global perspective. And so Chris's question, which he asks whenever he gives a presentation like this is, if you click on the next one, can we get a separate slice of this for primary care? And that inspired us to commission this study. And at this point, I'm going to turn it over to Mark Friedberg, who is one of the authors of the study, to tell you a little bit more about his work. Mark, are you online? Are you on mute, maybe?
Hi, Mark. It's Lisa. I'm going to just make sure that you haven't been muted here.
Hello, this is Mark Friedberg. Sorry about that. I hit the wrong button.
That's okay.
Thank you. Yeah, thank you, Rachel, for the introduction. And thank you, everybody, for inviting us to present this work. So, as Rachel mentioned, we, along with colleagues at Baylor Health Purchasing, did a study for Milbank, basically trying to do a proof of concept exercise to calculate the percentage of total spending that was on primary care within not a nationally representative sample, but a sample of 10 willing, high-performing health plans from around the country. And the impetus for the study was really just to see if health plans could execute a similar set of measurement specifications so that we could have comparability across them. As Rachel mentioned, different states have been using different definitions of primary care spending, which makes it hard to compare, let's say, Oregon, which uses one definition, to Rhode Island, which uses a different one. The idea here was to have something that could be comparable across plans in different states and different parts of the country. The link there, which I believe you'll all be receiving, goes to the report, which has a lot more detail than what I'm about to present on today's presentation. Next slide. As I mentioned, the scope of this study was relatively small, and these are only commercial health insurers. We did not, in this study, seek to include Medicaid or Medicaid managed care plans, nor do we include Medicare, neither fee-for-service Medicare nor Medicare Advantage plans in this particular study. We did, however, try to get health plans that were high-performing, meaning that they did well on NCQA's Quality Compass. And within those health plans, we took all comers. So not just their fully insured populations, but also their ASO products if they had those. Next slide. Of the health plans that we identified, and the folks at Baylor really did the recruiting, they had to have at least overall quality ratings of 80% and a score of 4 or 5 for prevention and treatment on the 2014 to 2015 NCQA plan rankings. We tried to get geographic representativeness among the sampled plans, so trying very hard not to sample more than one plan per state. We contacted 29 plans and 11 agreed to participate. Of those 11, only 9 were able to provide usable data. Next slide. So how did we define primary care spending? There's lots of different ways to do this. And we decided to actually include several different definitions within the study. To do this, we consulted with other researchers and with insurance commissioners from around the country. And we worked with health plan staff to calculate primary care spending, both overall dollar figures and also primary care spending as a percentage of total health plan spending in both 2013 and 2014. We included both HMO and PPO products. We separated those so they're not lumped together here. And as Rachel mentioned, we tried hard to get both fee-for-service payments, which were relatively straightforward to get for most plans, and non-fee-for-service payments. So these are your capitation, your bonuses, shared savings. Those were decidedly not straightforward to get. And we asked plans that were working with us to stratify those payment amounts within certain demographic groups and also within 2 comorbidity groups, so diabetes and asthma. Next slide. So how do we define primary care? Basically, we did it in 2 main ways. First, by the specialty of the provider, and we went from a relatively restrictive specialty mix, so only your core primary care specialties like family practice, general internal medicine, general pediatrics, and general practice, to a more general grouping of specialties. And in the most general specialty group, we actually did not include the specialty of the provider at all, but just included anybody that the health plan designated as a PCP. In parallel, we did a definition by service code. And there we looked at, on one hand, a more restrictive definition, which was traditional fee-for-service E&M codes and some preventive service codes. These are the kinds of codes that are used in CPC Plus and other primary care-based attribution systems to attribute patients to primary care physicians and thereby to their practices or their ACOs. And our results in a nutshell were that when we looked at the amounts of primary care spending, there actually wasn't that much of a difference as you liberalized the specialties that were included, but there was a fair amount of difference by service code. So if we included only that fairly traditional set of primary care services versus all billing done by primary care providers, that actually ended up being a more substantial difference. We also found, and this is sort of obvious in retrospect, but we hadn't seen anyone report this previously, that the percentage of total spending on primary care was quite a bit higher for children than for any other age group, and it decreased monotonically. So as it with each increasing age group, we saw a smaller percentage of total spending devoted to primary care. Next slide. So here's just a sampling of the results that are in the report. In the top table here, we're showing the dollar amounts for per member per month primary care spending, just for that more narrow mix of services, the primary care services. PCPA is that more restrictive definition I mentioned of the family practitioners, general internists, general practice. And PCPD is everybody who a health plan might consider to be a PCP, regardless of what their specialty was. So that would include, of course, people you might think of, like gynecologists, for example, who might be for some in some plans be considered PCPs, but also some specialties that we hadn't really considered before doing the study, like some health plans consider naturopaths to be PCPs. We went ahead and included them as well in that PCPD definition. And if you just follow across the top row there in 2014, in the HMO product, you see there's really minimal difference in the median primary care spend between the more restrictive definition of PCPs and that more liberal definition of PCPs. It goes from $16 to $17. One other thing to note about these estimates, and you'll see this in pretty much every cell we show, there's a huge range. So while the mean was $16 for PCPA, the range was $7 to $23 from the lowest spending to the highest spending health plan. That's a heck of a range. And we don't, on the basis of this study, really know whether that's due to true differences between health plans, differences in case mix, or whether that's actually due to differences in how health plans implemented the measures. We tried as hard as we could to be consistent within health plans, but we didn't have direct access to the data ourselves. And because this is the very first time these particular measure specifications have been used, there's always the opportunity for error introduced by different health plan analyst interpretations of the specifications. So that's always a possibility as well. We also saw, comparing HMO to PPO, again in that first chart, that PPO spending on primary care was a little lower than HMO, and that was consistent across all comparisons. Below, if you look in the next table below that, we see this, now what we've done here is we've liberalized the definition of what it means to be a primary care service. So this is no longer those traditional primary care attribution codes. It's everything a PCP might charge for. This would include office-based surgeries, mole removals, if they do in-office testing, all of that gets lumped into these numbers. And so here you see that the difference between PCPA and PCPD widens a little bit. So just looking across that top line again, for HMO in 2014, it goes from a mean of 22 to a mean of 26. But that difference is dwarfed by the difference between the top and the bottom table, where if you compare the top line of the top table to the top line of the bottom table, you jump from $16 to $22 per member per month within that more restricted definition of PCPA, and within the more liberal definition PCPD, jumps from $17 to $26. So really the bigger difference here is within what we consider to be a primary care service rather than who we consider to be a primary care provider. Also, in the bottom two rows of this table, we started to include the non-fee-for-service payments. And there you see there are some differences that are sort of they're not quite as large as within fee-for-service when we unrestrict the PCP, rather the primary care service definition, but there still are some. So if you compare the first to third row of that bottom table, we see that when we start to include non-fee-for-service payments, the average per member per month spending on primary care goes from $26 to $32 for HMO and from $23 to $27 for PPO. And again, the ranges are quite wide. Next slide. I think we went 2 slides. We could just back up 1. Great. So now we're not showing dollars, we're showing the percentage of total spending that's devoted to primary care. And in the denominator here, we have all spending by the health plan on these members. So not just the medical spend, but also the spend on prescription drugs. And you can see that between about 4.5% and 5% in that top row of total spend in fee-for-service HMO is on primary care. and that's within the more restrictive definition of what we consider to be a primary care service. If you go to the bottom table, see it jumps up again. Not a surprise, since these are over the same denominator of about 6 to 7.5% is now considered to be a primary care spend. And if we use the most liberal definition in that third arrow on the chart, you see that it can get as high as 8.5% of total spend is being devoted to primary care once we include all non-fee-for-service payments as well, with a wide range ranging from about 3.5% to around 14% across the plans that are included. Next slide. So this shows the age finding that I mentioned earlier. Just focusing on the middle, well, the leftmost column shows the age groups. We have the kids in the top one, and then 19 through 24, and decades all the way to 55 through 64. We don't have 65 and over because we did not include Medicare in the study. And you can see that just looking at the primary care spend, this interesting thing happens. So for children, they actually have the same spend as, on average, as adults aged 55 to 64 on a dollar basis. But if you look at the percentages, those really fall off a cliff as you become not a kid, but an adult, and they keep going down. And what's going on there is, first there's a drop in primary care spending on a dollar basis that then slowly re-increases as you age. But against that, what we're not showing here is, and that's in the report, is the denominator is just monotonically increasing the entire way through. So as you get older, you start to spend more money on everything else than primary care. And that's why the percentage of primary care spend is so low among the oldest group here, and so high among the youngest group, even though they actually have the exact same average absolute spend on a dollar basis. Next slide. So some important limitations here, basically as a consequence of the design and scope of the study. It was a small number of high-performing plans that were included. These are not nationally representative numbers, and probably shouldn't be used as benchmarks because they're not nationally representative. These were self-generated. They were voluntary participants. They're not audited, and these plans were actually quite challenged by the request in some cases, especially on providing non-fee-for-service spending figures. It turns out health plans, unlike their fee-for-service claims data, don't really have in general a great audit trail on the non-fee-for-service side of things. In a lot of cases, they sort of know when a check went out or what the total payment was to a given organization, but asking them to figure out how much of that was a medical home payment versus how much of that was a pay-for-performance bonus versus how much of that was shared savings. Oftentimes, those data are not available. They're lost in the sands of time. And so, if this were to become a more rigorous effort, we would want to probably give health plans a good lead warning to start collecting new kinds of data they're not accustomed to collecting on the non-fee-for-service side. Another big finding, limitation here, of course, is that regardless of definition of PCP, we started with insurers' designation of a PCP label. All the insurers in this study had such a label, and you'll probably find that in pretty much any health plan that has an HMO or managed care product where they really do need to have a PCP label for every provider. But some health plans might not have that. And a big one, of course, is Medicare. Traditional fee-for-service Medicare does not have a PCP label at all. And so these specifications would have to be modified for any health plan, including Medicare, that does not have a PCP designation maintained by the health plan itself. Next slide. And I think here we're going to go ahead and turn that back over to Rachel. Thank you.
Thanks a lot, Mark. So this is just a quote from a recent New England Journal perspective piece that Chris published, and I think we have a link at the end of the presentation, so I'm not going to dwell on this. But just basically, it establishes kind of our bottom line here, which is that the use of primary care spending is a way to assess how oriented health systems are to primary care. And that's really the general argument that we're using when we talk to various groups and also when we talk to states about policy in this area. So Lisa, if you can go to the next slide. So in terms of some broad messages, what were we trying to accomplish here? What did we take away? So part of what we wanted to accomplish is to establish that it is important to measure primary care investment, that it is feasible to develop and use primary care spending measures. But we need to recognize that resources are required. And if you are going to implement measures like this, you need to plan for it. And that planning involves both the insurer side or health plan side of the equation, as well as the state side or the convener side, if somebody is collecting and analyzing and publishing the information. And kind of related to that, it's important to have a process that is transparent and data that is trusted. And I know I'm preaching to the choir with this group on making that point. Next slide. One of the things that's come up in my conversations with groups is we have been talking to a lot of different people about this. Is it's important to keep in mind that when we're talking about measuring or defining primary care, that you want to build the measure or definition to fit your purpose. So for purposes of measuring spending, what Mark just articulated, although it is pretty complex, is a relatively simple way to define primary care. But I have talked to several states and other organizations that are interested in primary care for other policy reasons, and there's a perfectly legitimate reason for stakeholders to get together and figure out other ways that they might want to define primary care. And Vermont, for example, has a primary care advisory group, and part of their purpose is coming up with consensus across the state on how they want to define primary care. So there's some overlap, but there's also a nuance of a distinction there, and I just wanted to make that point. For purpose of measuring spending, simpler is better. The second is that if we can start to work towards standardizing these measures, obviously it will help to facilitate valid comparisons and support broader uses of the data. So for example, we've talked to a number of people who want to establish or validate the relationship between primary care spending and total cost measures. These measures could also be helpful to evaluate the impact of different kinds of value-based payment strategies and to compare those models in terms of how effective are they to increase investment in primary care. But it would be helpful to start to move towards more standardization in a field that obviously has a lot of flowers blooming right now. Next slide. So in terms of next steps, we have quite a few different things going on. We're working with states and also with the American Academy of Family Physicians to help to replicate these measures and to advance legislation or regulation at the state level. Part of this is to support a collaboration among the New England states that are interested in taking the specifications that Mark has developed and using their data to see if they could come up with good comparisons by using a standardized measurement tool. So that's just one example of the kind of thing that we're doing. We're also working to disseminate these results at professional meetings of particularly primary care groups and also at other presentations. So for example, Mark has submitted an abstract focusing on his Medicare data analysis, which is the next chapter in that story to Academy Health for the annual research meeting. Next slide. We continue to collaborate with a variety of groups who are interested in discussing and possibly refining the definitions. And as I just mentioned, we have now funded Mark to do some additional research using and adapting these measures to establish Medicare primary care spending levels. We're also connecting with others who are involved in various forms of reporting on healthcare expenditures, such as the Healthcare Cost Institute, and to see if we could get them interested in utilizing our measures and work with them to understand how the measures will compare to the results that the initial study got. And finally, of course, we continue to support multi-payer models for primary care support, including the multi-state collaborative. Next slide. So just to close out the formal presentation part of this, you have my contact information, and obviously you all have Lisa's contact information. And at the back of the slide deck, we're not going to talk through it, but there are links to many of the resources that we mentioned during the presentation, and also a little bit more specificity from the report on the primary care definitions that were used in the initial report. So Lisa, I think that's it for us in terms of the formal part of the presentation, and we're happy to entertain questions.
Sure, that's great, Rachel. And thanks so much, both Rachel and Mark, for an excellent presentation. I'm just going to go to that next slide so people can see this is your list. Actually, there's more than one in terms of the various references and resources. So, and we, as I said, all of this information will be available both on our website as well as sent to you following the event today. So not too many questions came up on our group chat, but I do want to make sure that folks are alerted to the conversation that was happening a little bit earlier on in that hour. This came from our colleague Richard Schank at the Health Collaborative in Ohio. Dick, I don't know if you wanted to just elaborate a little bit on the question that you had asked, because it looks like there were multiple parts to it.
Can you hear me now?
Yeah, we can hear you. Great.
Yeah, one of the things that we've been trying to sort out in the CPC Plus program here and following our all-payer claims data with regard to that is that question of who do you include in primary care. It's pretty much defined by the project for us, but I can see already within the state that there's, and I would be interested in more information on how you determine primary care by coding of various services, because I've been approached by several internal medicine subspecialties, non-invasive cardiology, some GI, that they say they do primary care, and that I think to some degree you could make a case for that. So I'd be interested in, is there a way of determining primary care just through the types of claims that they submit?
Yeah, that's a really interesting question. So I don't think you can determine it on, and the report gets, I highly encourage you to read the report where we have a little section discussing different ways of defining primary care and which ones are based, doable based on claims data. So I don't think it's going to be very possible to determine primary care on the basis of the type of claim only. I say that for a couple of reasons. You have two problems. On one end, you have the non-specificity of the E&M codes. So, an E4 is an E4, regardless of whether it's a consultant who's really just dealing with, one organ system or one, very self-delimited problem, or it's done by somebody who's truly serving as a primary care physician or provider, whatever their specialty or training is, who's dealing with multiple problems and trying to coordinate care and do all the functions of primary care. So you have the problem of non-specificity of the codes, but there's another problem which this study really highlights, is that we think there's evidence here that even if you stick to those office visit type codes, you're going to really be missing a lot of the services that primary care providers might truly be providing, and that would be consistent with the definitions of primary care that most people consider to be the right ones, because they're being comprehensive. It's considered good in primary care to provide some office-based surgery for patients. They don't have to go, let's say, see a dermatologist for every minor skin lesion, and can instead have that dealt with in the primary care office itself. and that's a nice feature of primary care. And if you exclude those services from the definition, then you're missing a fair amount of actual primary care spending and the kind of thing you might even want to incentivize. So that's the danger of only looking at the E&M, the CPT codes themselves, and not trying to also intersect that with something about the specialty of the provider. Now, we had an easy way of handling this in this particular study because all the health plans, as I mentioned, designated all their providers as either being a primary care provider or not, because they all had managed care products. And so if a gastroenterologist is designated by a health plan as being, a primary care provider in their managed care product, and I'd say, sure, our most liberal definition would have included that gastroenterologist. But there might be some gastroenterologists who are not so designated by a health plan, and they would not be included. So it wouldn't include all gastroenterologists. Now, moving this over to Medicare, that becomes a harder thing to do because traditional Medicare, fee-for-service, does not have those flags for specialists.
Thank you, Mark. Dick, do you have a follow-up question or anything that you'd like to explore further before we leave this topic?
I was just reading into the, somebody chatted in.
Bill Golden, yep.
Yeah, so interesting. Well, the only other thing I think besides a specialty type of cross-check with the claims, I think there's kind of a temporal approach that we're finding out as well. And I think the best example of this is in oncology. And I think that if someone's going through cancer therapy, and we've had some of the oncologists also talk about this, is that almost there's a kind of a takeover of the primary care function by the oncologist while they're undergoing the treatment. And I think most primary care doctors are kind of reluctant to prescribe for an oncology patient simply because of the possibility of drug interactions and the like. So I think that you may also find that there's a timing issue with regard to during certain types of therapy, and whether we want to call them episodes of care or what, but those episodes could go on for a year or more. How do we handle that aspect of it as well? So I'm probably getting way too much into the weeds, and it's kind of threading the needle way too finely. But I do think that it's just things that have come to my mind as we try to sit here and figure out our data. So.
Right.
Yeah.
Go ahead, Mark.
Oh, I was going to say that's a really interesting point. In the absence of so there's different ways one could try to attack that. You could or try to detect those situations where you have like the primary care baton basically being handed to a specialist for a defined length of time, let's say during active cancer treatment. And I'm a PCP myself. I completely agree with your characterization of the situation there. Sometimes you have a de facto PCP for a while. It's not your permanent PCP. Hopefully the cancer goes into remission and the baton gets handed back to the PCP. So during that time period, you might be able to detect it in claims. But better yet would really be if this would be a new data collection activity for health plans, but it seems like it would be doable in the internet age. Would just be to have a regularly updated PCP baton for every member, and say, okay, on a given date, we're going to record exactly who the PCP is, and it's going to stay that way until we receive a notification that the baton has been handed over. And you're going to have to gather that data somehow, and you could have software tools that try to detect events like new active treatment of cancer, or you could ask the providers to submit those data or the patients themselves. But that area is pretty wide open in terms of methods.
Great. I just wanted to read the comment from our colleague Bill Golden from Arkansas Medicaid, and specifically what he said was that the subspecialists are what he refers to as principal care, not primary care, which is a good distinction. They're not picking up the phone at night for UTIs, et cetera, but some oncologists, rheumatologists are seeing the patients more than anyone else for core issues. So Bill, I don't know if you are able to speak. Did you want to just elaborate on that before we move on to another question?
Can you hear me? I don't know if I'm on the call or not.
Yeah, we can hear you. Yep.
Okay. I don't know how the system works. Okay.
Well,
this goes to the ACP a long time ago. and about the need about how you handle the subspecialty community. But they are principal care, not really primary care, you know, and it gets into issues of, you know, there are some activities like we've seen in the Project Sonar in Illinois with Crohn's disease, where the management of Crohn's becomes a core component of, you know, the kinds of primary care things you would expect. And they've gotten some very nice quality and efficiency data out of that. But some of the other stuff is, you know, few and far between. You know, do you really need a cardiologist to take care of hypertension or low-grade, you know, class 2 heart failure? So some of this is a reflection of a little bit of a discomfort and threat. But I think the average cardiologist is still pretty disease-focused and not comprehensive. The ACP apparently is going to embark on a new work group to look at how to reinvent maybe reimbursement, how the healthcare system works. That's going to be their project for the year. And I think Peter Balch is going to be involved with it. And I just presented at the college meeting about a lot of this stuff and talked about how the HCPLAN committee wanted to blow up and get rid of E&M codes. And it actually got applause. So, you know, I think you know, the issue of trying to reward people for managing populations and panels rather than visits is, I think, the key issue going forward.
Great, thank you. I'd like to turn to another question that came from our colleague Nicole Merrithew in Oregon, and I'm delighted to have her on. As you can see, Oregon has been very prominent in this work in terms of their legislation and recently published report. So Nicole asked specifically, have you noticed regional variances in primary care spend based on competition and or delivery system type present in a given area? And then a follow-up, which is what considerations need to be made for these regional variances when you're setting primary care spend standards? An easy question from our colleague in Oregon.
Yeah, so the question was around price variation regionally. Yeah, so in the report, we tried to deal with that in one way, which was to look at the ratio of utilization of office visits across the different health plans in different areas. And that ended up, you'll see in the report that there was quite a range across different health plans. It's hard to know, for the reason I mentioned earlier, because this is the first time these specifications were applied, whether the variation we see is real or if it's due to differences in how people interpreted the specifications. I think that's a challenge in the commercial sector. The price thing is a biggie. On one hand, you want to adjust for price differences to get some kind of measure of to avoid confounding by something like this, where let's say in one region there's a large health system that can command high prices and happens to have a lot of the primary care services within it. That might sort of, in a way, artificially inflate the primary care spending. But on the other hand, there are resources going to primary care, even if it's due to price and not utilization. So whether to adjust for that depends on, I guess, the purpose for which you're going to use the data. Fortunately, in the Medicare setting, we don't have that issue, and it's relatively straightforward to adjust for geographic differences that are baked into the Medicare payment formula.
Yeah, and Lisa, if I can just piggyback on that in terms of the last question, I think that some of the discussion we've had so far, both how to define primary care, how those definitions might be used in terms of measuring a primary care spending, how this all fits into the transition to new payment models. When we're not going to have claims data, we're going to have other things, to look at in terms of value and spending. And then finally, how to understand whether it's regional differences or differences among plans, I think are exactly why I think that either states or entities such as those sponsoring the CPC Plus type projects around the country are a good forum that can provide the governance structure and the transparency of discussion and decision making around those issues. This is obviously a very new thing. We don't have enough data to really make very definitive judgments. So that's part of the reason we're mainly focusing on getting more people to use the measure, so we'll have more data. But I think that it is important to keep the governance and policy aspect of this in the back of our minds as well.
Great, thank you. Nicole, hopefully you're still on. Did you have any follow-up questions or comments?
Can you hear me?
Yes, we can.
Yep.
Yep.
Okay, great. No, I think that's very helpful and helps to answer the question. In terms of the follow-up question that came through about the spend versus price, I mean, the question really was about the relationship and the link between the price that would therefore obviously impact the overall spend. I think that one thing that we have started digging into and are noticing a little bit is that in some areas where it's not even necessarily about the primary care spend that you'd have in the numerator, but if you're looking at something in terms of percentages and not the absolute spend, where depending on what some of the hospitals in an area are allowed to charge, again, kind of getting to the competition piece a little bit and the kind of hospitals present and the influence or lack thereof that a health plan may have over setting some of those prices, that it can have a big impact on your denominator in terms of, you know, things outside of primary care. And so if you're looking at the percentage of spend, that alone could potentially have a big impact. And I was just curious to see if that's something that you guys had looked into at all.
Thanks, Nicole. Rachel or Mark, did you want to respond to that or with any further detail?
No, I don't have anything to add. Thanks.
Great. So Eric Muther had actually asked the follow-up question that Nicole was referring to and specifically said that he thought the question was about spend, not price, and was curious about spend rate differences. Eric, did you want to follow up on that for our speakers?
I think the clarification that was just made was helpful. I guess my only point is that doing research on price variation has a different intended implication than doing research on spending variation. Obviously, price is a component of the total spend, is a factor. It's effectively utilization times price that determines the spend. But if you're trying to reduce price or understand, unwarranted variation in pricing or market-based pricing and how that affects the spend, that is sort of a separate, study. If you're trying to look at primary care spend as either a mechanism to bring down or reduce the growth rate of total healthcare spending overall, those are just two separate distinct things. So I was just curious to see whether the report was able to tease out differences in, I guess it would really be more utilization of primary care services versus, the variation in pricing. Because I think there's been a reasonable amount of research to show that there's variation in pricing. So that's why I was asking.
Great, thanks. Rachel or Mark, did you want to comment on that specific point?
No, I think that was really well put. They're just different questions, and we did not in the report because we didn't have direct access to the price data on a unit basis. We couldn't observe price directly, so we sort of did our best to indirectly get at that question through the utilization data and the ratio of the primary care services that are provided by PCPs versus other providers. But it's admittedly imprecise, and really you'd have to have direct access to the claims with the prices, which of course are pretty sensitive a lot of the time, to directly to truly decompose differences in spending into price versus quantity. So I think one other thing about just an example again of why you wouldn't necessarily want to adjust for price across different areas. I guess it's an open question empirically, at least in my view, whether the best way to measure the primary care orientation of a health system, geographic region or a health plan is on the basis of utilization standardized for price, or whether you should go ahead and incorporate price. Because I've heard of, and this probably won't seem like a surprise to many people on the call, there are metropolitan areas where certain specialties are highly consolidated, but the primary care providers are not. And so, in addition to already having more RVUs per, procedure or per hour eligible to, let's say, a procedural specialist, they might also have a higher conversion factor, dollars per RVU, with their commercial payers due to their market power relative to PCPs who might have something at Medicare or lower. And when that's the case, and if you tried to wash away the effect of price, you'd really give that area maybe more credit than it's due for being primary care oriented.
And Lisa, I just wanted to add one thing. So one of the debates that's going on out in the world around these issues right now, in terms of how states should think about this, is whether they should try to go ahead and measure primary care spending using their all-payer claims databases, or whether they should go the route of the Rhode Island approach, where insurers have a specific reporting template that they report into the state specifically for this purpose. And the reason I bring it up in this context is that at least when last I followed this topic closely, all-payer claims databases often don't have price information. So it would be difficult to tease out some of these issues if states relied only on that reporting. Conversely, insurers actually do have their own pricing information. So while obviously the insurers are not necessarily enthusiastic about a new data reporting requirement, but going back to the building to purpose, if that pricing information becomes an important component to really teasing out real differences in spending as opposed to price-driven differences in spending, it may back us into basically concluding that we're going to have to rely on the insurers for some level of additional reporting if we're going to make this work right.
Great. So we have about 5 minutes left. I'm going to just read something that came through the chat for those of you who are on the phone. Another comment from Bill Golden, specifically around all payer claims databases, which are there almost uniformly de-identified, which does limit the richness of data analysis. And that's especially true around provider-specific variation. So I want to turn our attention to one other question that came in on chat, which is specifically about how rural versus urban settings affects the primary care spend. So just thinking about a rural setting where you have less specialists in general, and with that, have you seen any pattern in terms of the spend increase on primary care? And if that's evident in your data thus far.
That's a really interesting question. The previous study couldn't answer that one because we didn't ask the health plans to give us data that were subdivided by rural versus non-rural areas. We will be looking at that in the Medicare study. So stay tuned. We don't have data yet. I'm not holding anything back. We just don't know.
Great, thank you. Rachel, did you want to comment on that as well? Or?
Nope.
Okay. Are there any other questions or comments for our colleagues who want to thank both of you for a really terrific presentation. This is very complicated stuff, and I just over again admire how you're able to describe it to us in such a way that we can start to understand it. I want to thank everybody for joining us today. And I would also like to just put in a quick reminder, an announcement I should have made earlier on, but as everyone knows, the Innovation Center has released another request for information specifically about input around direct provider contracting. This is an important topic, and I think people have very strong opinions about it, and also it seems like there's a bit of a dearth of information. So we at the fund are going to set up a special webinar with a couple of guest speakers who have been deep in thought about this topic for some time. So stay tuned. You'll be getting an announcement of a webinar to be set up sometime in the next couple of weeks. The deadline for submitting comments for this RFI is the 25th of May, so it's a pretty short turnaround. Thanks everybody once again. as I said, everything has been recorded and will be available on our website, as will all of the documents that you've seen. Thanks very much. Bye-bye.